of you who are attending this session and the volunteers. Uh, so we all know that trabeculectomy, in spite of all the advances that are happening, it is still the gold standard and the most commonly performed surgery. And the success of the trabeculectomy actually depends on the bleb, that is how well it functions and filters, its anatomy, pathology, physiology, its functioning, and the histology. And we need to take care of this bleb right from its conception, that is when you're actually doing your surgery till it matures, it grows as an adult, and for the lifetime also, because at any time any complication can happen, especially when you have used certain antifibrotics. So this session is all about nurturing that bleb right from its conception to years later. And I'll begin this session with my own talk on the art of preventing bleb failure. So I'll be talking on the prevention of bleb failure, mainly focusing on the do's and don'ts of the surgery. The screen sharing. So the success, all of us know that the success of trabeculectomy is unpredictable and it is unguaranteed. And unlike cataract surgery, we have lots of complications, failures, and surprises in the post-operative period, even though we may have done the same type of a surgery every time. And therefore, it's very important to take care and nurture that bleb which we are going to form, both in the respects of prevention through meticulous surgery and intervening at the correct time through a careful post-op vigilance. So it all begins from the pre-op period, where need to assess the risk that the patient has for developing failure. Especially we know the cases like young age, males, certain races, the type of glaucoma the patient has, whether it is congenital, juvenile, traumatic, or secondaries. The surface inflammation, especially if the patient has been on long-term topical drugs or if there is an inherent ocular surface disease. And if the ocular surface is also scarred, either because of a disease or because of some prior surgery. And therefore, accordingly, we may need to withdraw certain high-risk drugs, and those we know that they are mainly prostaglandin analogs, they are pilocarpine, and even the Rho kinase inhibitors have a questionable effect because of the significant amount of hyperemia they cause. While we are withdrawing the high-risk drugs, we need to keep in mind that the IOP should be as low as possible in the pre-op period, so we may have to substitute with acetazolamide or mannitol if required. If the surface inflammation is significant, we may need to add topical NSAIDs or steroids to reduce the inflammation and allow the ocular surface to regain the health. Blood thinners, if possible, should be discontinued, but always in consultation with the treating physician or cardiologist. And of course, a thorough pre-op ocular evaluation, both for a fresh glaucoma perspective, to rule out any contraindications for the surgery and to see if there are any other conditions which may need prior management or which may influence the success of your surgery. Coming to the intraoperative part, which is most important, surgery will work well only if you do it reasonably well. And what we follow now is the Moorfield's safe surgery system. So the first change that has happened is switching over from a superior rectus brittle suture to a corneal fixation suture to avoid any trauma to the conjunctiva, which we know is a very important tissue for the glaucoma surgery success. The conjunctival dissection which we do should be using a traumatic forceps. Never use a traumatic forceps to handle or manipulate the conjunctiva. Avoid any kind of an excessive manipulation of the conjunctiva or tenons, and see that you do not cause any tears, buttonholes, and also avoid multiple relaxing cuts, because that again will necessitate a number of sutures. Do not limit your dissection just posterior to the limbus as you do for a MSICS surgery, but you have to create deep pockets all around, posteriorly and on the sides. If it's a case of prior surgeries done, identify the virgin conjunctiva, and this you can do either in the pre-op period or you can do on table, injecting fluid subtenons to identify the areas of scarring and see whether the conjunctiva is free and getting elevated and where it is fibrosed and adherent, and which are the sites you would want to avoid for your surgery. For hemostasis, over-enthusiastic application of the cautery should be avoided, and also see that your cautery does not touch the conjunctiva, because all this will cause tissue injury, necrosis, scleral shrinkage, and inflammation. If you are doing an overlay type of an MMC application, which is very commonly done nowadays, varying concentration and duration should be according to the risk of failure that is there and according to the inherent health of the conjunctiva and sclera. Instead of just one flap lying over the scleral flap region, multiple sponges should be used under the conjunctiva in all the directions so as to cover a larger area, because what we want is not a localized bleb but a more posterior and diffuse bleb. And always remember to count the number of sponges that you have inserted and wash thoroughly with your fluid. And while the MMC sponges are laying inside, see that they do not stay in contact with the cut edges of the conjunctiva, because that will again hamper the healing. With respect to the scleral flap dissections, avoid a multiplanar dissection. It should be a very regular, smooth, uniplanar dissection, swiping from one end to the other. The sides of the flap should also not be cut flush to the limbus. See that the sides, they remain a little posterior. Avoid cutting of the perforators because they may start bleeding excessively, and see that the flap is of adequate thickness and according to the thickness of the sclera itself. Too thick will lead to more resistance and underfiltration, and too thin will lead to hypotony and may even cause dehiscence of the flap. With respect to the sclerostomy, what is most important is the anatomy. That is where you are making your sclerostomy. It should be at the junction of the blue and white zone. So 2 radial cuts first, then an anterior cut joining the 2, and then evert the flap, confirm that the pigmented line that you see, that is the trabecular meshwork, and then excise it. So that is an animation, that is how you do. With respect to the peripheral iridectomy, it should always be broader than the window. For this, pull it at a stretch and then cut it. Avoid any kind of a forceful pulling of the iris, as it may cause iridodialysis and even zonular damage and lens damage. And after the iridectomy is done, do not insert any instruments into the AC for repositioning, because through your iridectomy you would write over the zonules and you may damage the zonules and even invite vitreous. So you can just put the flap back and stroke gently over the limbus, which will allow the iris to fall back into its place. For the scleral flap closure, again see that you take, if it is a triangular, 1 at the apex. If it is a rectangular, 2 at the 2 ends. The other sutures should be towards the limbus and not towards the apex, because again here we want the aqueous to flow posteriorly. So do not suture them posteriorly but more towards the limbus. The knot should be buried. You can take releasable or adjustable to have the bleb titration post-operatively. You can, but at least mandatory 1 interrupted is necessary. And after this, as a beginner, you can check your filtration and check for the adequacy of the sutures and your patency of the ostium. The conjunctival closure should be as totally watertight. In case of a limbus base, you can take a continuous suture. In case of fornix base, you can take just 2 wing sutures. And if necessary, if you feel that the conjunctiva is getting retracted and it is not watertight, you can take central anchoring sutures. And again, after conjunctival closure, do a bleb titration to ensure that the bleb and the AC are forming in proportion to each other, and it confirms the tightness of the sutures and the patency of the ostium. Post-operative vigilance is as much as necessary to prevent complications. All pre-operative IOP lowering medications should be discontinued, because sometimes we forget to explain this to the patient. They continue all the pre-operative meds, especially acetazolamide or glycerol, and then it leads to inadvertent hypotony. The steroid route duration and drug would depend on what is the degree of scarring that is there, the level of bleb inflammation, and what is the inherent risk of failure in that patient. And of course, a cycloplegic to deepen the AC and for the control of inflammation. The biggest challenge in the post-operative period is recognizing the need for intervention, choosing the type of intervention that is needed, and most importantly, intervening at the right time. And the biggest danger for us is having a bleb failure. So these are the signs. You can see any local increased amount of hyperemia, excessive vascularization, a typical corkscrew appearance. The bleb, instead of getting moderately elevated, diffuse, and just mildly vascular, it may get small or flat or encapsulated, and a trending rise of increased intraocular pressure. So it is very important to diagnose this bleb failure, and the most important key is doing a gonioscopy post-operative, which will tell you whether the block is internal or whether it is an external, and can be perhaps cured by a digital massage or other intervention. But always remember that if you intervene delayed, or if there are any additional interventions that are needed post-operatively, all these will ultimately increase the risk of bleb failure. So to conclude, The artist is one who performs careful and meticulous trabeculectomy, keeps a close post-operative follow-up, controls the scarring and inflammation, judiciously uses the antifibrotic agents, promptly recognizes a complication, evaluates the cause of failure and complication, and aggressively manages. Thank you. I'll now invite Dr. Meeda for her talk on careful and real-time visualization of the Bleb. And if there are any questions, we can take them at the end of the session.
Thank you, Dr. Purvi, for giving me this opportunity to speak on this subject. My topic is tracking the Bleb my way. So, as we know, trabeculectomy is the gold standard, and which has been practicing. We have been practicing this for so many years. Long-term surgical success of TRAP depends on persistent lowering of the IOP without using further glaucoma medications, stabilization of visual acuity and visual field in addition to IOP reduction. This is dependent on formation of filtration bleb at the sclerotomy site and subconjunctival scarring. Prevention starts intraoperatively, as we already discussed. At the time of surgery, has to done very carefully. You have to master your surgical technique and including the perioperative medications. It continues postoperatively also, and there is necessary to promptly recognize the failing bleb to maximize the likelihood of its rescue. And a failing bleb requires careful evaluation to determine its predominant cause. So first 2 weeks there can be hyperemia, excessive vascularity. First 2 months there can be increase in the intraocular pressures, small bleb can be seen, and next is the encapsulated bleb, a small cystic bleb or a flat bleb. So these are the bleb patterns which has been identified previously, like a very low IOP, elevated bleb, elevated diffuse bleb, localized low type of bleb, and localized encapsulated blebs. So when not to intervene, also we have to remember that the pressure which we wanted postoperatively, if it is same and it is remarkably stable, you need not intervene, you just have to monitor these blebs. So the main purpose of the trabeculectomy is to prevent the progressive damage to the optic nerve head, and if you have achieved this, then it is well enough. If the IOP is stable, maximum post-op IOP is same as pre-op IOP with MMT, then also you should wait for intervention. Even if you want to start a single AGM, it's okay, because this can be considered as a partial success. So can we resuscitate the failing bleb? Gonioscopically need to confirm a patent sclerectomy. Evaluate bleb's function and potential. Apply pressure 180 degree away while observing through the slit lamp. So you know the AC is not flattening, and you can perform it forcefully if no bleb forms with a light massage. You can push directly adjacent to the side of the scleral flap with a blunt object or a cotton swab and see if it is forming. Apply pressure with a finger directly over the bleb through the upper eyelid also, so the whatever fluid is collected there gets displaced, and this also can resuscitate the bleb. So within early postoperative first to 2 weeks, you can use aggressive use of predacetate, administer subtetanus 5-FU, release the releasable suture, laser suturolysis with massage also can be tried. First 1 to 2 months, you can again try releasing the suture, laser suturolysis, predacetate drops, subconjunctival 5-FU or triamcinolone along with digital massage. And after that, you can still attempt laser suturolysis, though the success would not be so good, but if you have used MMC. Needling in OPD can be tried at slit lamp with wide illumination and low magnification. In OT also you can try, because patient would be comfortable under microscope, and or you can have a dissection with internal revision in OT. So these points would be discussed by later speakers. Routinely assessment of long term is done by clinician on a slit lamp, but it can be challenging. Outcome of these TRAP patients is different for different patients, and there is individual variation, and bleb morphology is an important factor and predictor for this. So there are many bleb grading system. They consider morphological bleb configuration. This facilitates the long-term follow-up of blebs and may predict potential signs of failure early enough to intervene. So this is a bleb. So according to Moorfield's system, we can grade this bleb. We all know about this, so I'm not going to detail. So they can be classified as diffuse, microcystic, flat, or encapsulated. The next system is Indiana bleb. These are the systems which are used commonly. So the parameters here used are bleb, central height, horizontal extent, vascularity, along with Seedl's leakage also. And there is third one, that is Indiana bleb appearance grading system, and Mainz Bleb appearance grading system. So this also considers height, vascularity, and transparency. So limitations is it is a depends upon bleb morphology and function, but it is subjective, and findings of bleb height and diameter and presence of microcyst or vascularization lies within the clinician, and determination of morphological appearance of the bleb gives no information of its internal structures. So we'll see UBM and OCT how we can help use this. So UBM is sensitivity is very high, 91%, and specificity is good. So eye cup is used in patient's eye, but the process is time consuming, and in a patient who has recently undergone trabeculectomy may not be useful because of the possible of risk for a bleb infection. So ASOCT, we know that it is a very new tool, and which can be used very clearly and comfortably for the patient. No coupling medium is used. Position and orientation of the scan can be localized and visualized, and it offers us a better alternative. So bleb patterns using ASOCT can be diffuse filtering blebs, cystic blebs, encapsulated blebs, and flattened blebs. So here you can see that the diffuse filtering blebs, you have multiple subconjunctival areas over here. You can find out various patterns, pockets of fluid collection, and low to moderate intrableb reflectivity is there. So cystic blebs, you find a cyst over there with a thick conjunctiva with a very low reflectivity of the fluid which is collected over there. Encapsulated blebs, obviously the wall is thick with a fluid, and you can see a steel offering around it. Flattened blebs, obviously the fluid drainage will not be more, and the conjunctiva and this reflectivity is much more higher without any intracystic fluid collections. So let's see them one by one in a real time scenario. So this is a Moorfield classification, this is Indiana classification, and this is a diffuse filtering bleb. There is a lake under scleral fluid, under the scleral flap over here, and you can see the root under the scleral flap. So this bleb is a avascular bleb, or V1 you can say. The Seedl's is negative, but the fluid is collecting over there, and it is circulating, and the pressure is good in lower teens. So this is again bleb where you can find out the scleral root. This is a avascular cystic bleb, and there is a suprascleral fluid space along with root under the scleral flap, which you can see here. So this is the internal ostium, and you can see there is a collection of fluid along with spongy conjunctiva overneath. Another patient, a patient we had undergone trabeculectomy almost 12 years back, and pressures are 13 in the right hand, left eye 15 to 17. So you can have diffuse ologen blebs. These are the diffuse ologen blebs. So ologen has been absorbed, and you can see a fluid space over there. Though the blebs are flat, the pressure is good in the right eye, and left eye it is now 15 to 17 with a collection of fluid over here, but still the pressure is not very high, like not above 20, but still now this left eye needs monitoring. Again, another patient who I had operated almost 22 years back in 2000, and his pressures are continuously for last 20 years 6 and 8. There is no macular hypertony. Can I go for a minute? So you can see that you can see the scleral flap. There is a fluid under the scleral flap, and you can see the conjunctiva. Though it is a cystic, it is a double walled, and you can see the spaces over there. So that's why the pressure is remaining low in this patient, and he's maintaining very well with this without any visual complications. So another same patient, another of the same patient, you can see the spongy conjunctiva, how it looks over the scleral flap. Next patient, again similarly you can identify the scleral flap, you can see the fluid under, you can see the spongy overlying conjunctiva. So there are multiple, here you can find out how the trab is behaving, you can find out the fluid and root under the scleral flap in this patient also. Pressure is 12 to 14, and next is ologen bleb. This is immediately after the after 1 month after the trabeculectomy with ologen, you can still see the ologen over here with partial resorption of the ologen material, and here afterwards you can see the fluid which is collecting and in the ologen and under the ologen which is partially resorbed. So ologen blebs are also good, which we can monitor here. This is again the internal ostium and the fluid pathway is there, and the conjunctiva is really behaving well. Again a few ologen blebs. So here you can see the bleb is elevated according to MBJS, the vascularity is 2, height is 3. So these are the good blebs. You can find out the internal ostium along with the fluid collection under the scleral flap and conjunctiva. So the take home message is monitoring of the bleb is crucial. Here we need to have all 3 parameters like serial IOP in post-op period, morphological grading and imaging with ASOCT. A failing bleb requires careful evaluation to determine the predominant cause, and timely and prompt recognition of a failing bleb is crucial to identify the underfunctioning blebs at an early stage, and this helps us to maximize the likelihood of its rescue. Thank you for patient here.
Thank you, Dr. Megha, for those wonderful images and the correlation of the clinical and imaging picture. And in fact, as she very rightly said, you have to actually understand what is an ideal bleb and keep monitoring it. And any deviations from those ideal, you have to be vigilant. It's not actually advisable to panic and intervene at the first moment you see a deviation, but you have to be more vigilant, perhaps a more close monitoring of the patient, and then you can plan when to intervene. I'd like to invite the next speaker, Dr. Dipanjan, who will be talking on a leaking bleb.
Good morning, and thanks Dr. Purti for giving opportunity in your IC. So this is a nightmare that every glaucoma surgeon undergoes if the bleb starts leaking. So why these blebs leak? So this is, we need to know that it is an essentially thin conjunctival tissue mostly, and it is constantly bathed by aqueous, and there is chance of leak. And prolonged antimetabolite use, like most of the time we use antimetabolites, and then there is a chance of formation of ring of steel, and the central part, so there is a compartmentalization, and the central part, the aqueous is there, and it is constantly bathed by this aqueous, and the superficial conjunctiva gives away, and the bleb starts leaking mostly when the leak is late. So there is avascularity, irregularity, dryness, all this leads to this break of the epithelium, and the 5-year probability of developing a bleb leak following a trabeculectomy with mitomycin C has been estimated to almost to 18%. So why leaking is unwanted? Because there is a risk of bleb failure, suprachoroidal hemorrhage, hypotonic maculopathy, and definitely bleb-related infections like blebitis and endophthalmitis. So it is important to discover a leak. So if we go through a history, usually the patient presents with increased tearing, momentary blur, discomfort. With clinical examination, if it is an early leak, usually it is a shallow anterior chamber. It's a late leak, mostly the patient doesn't present with a shallow anterior chamber, it is a chronic hypotony. But many leaks for many patients, they're absolutely asymptomatic. So it is always prudent to perform a little test in all cystic blebs when we see. That is very simple, putting a fluorescent strip in the conjunctiva, wet fluorescent strip, and we can see a clear stream of aqueous within the fluorescent leg if the bleb is leaking easily. But many times, if you suspect a leak, you can press a little to see the stream. So how to deal with early post-op leaks? So what we need to assess the briskness, how fast it is leaking, the extent, the clock hours of leak, and whether it is associated with a tissue necrosis. The commonest thing is a stretch hole or a buttonhole through the suture that we use, usually a Vicryl or a nylon, whatever. So for this, simple pressure patch for 48 hours, if it is less than 1 millimeter or around to 1.5 millimeter, on the near limbus part of the conjunctiva, it is good. If not, if it is not closing with that, we can put a purse string suture with a tenno nylon, but please use round bodied needle, because if we use a tapered needle, tapered cut, it can again give a stretch, so the blade can leak again. And if we are suspecting a gaping at the limbus, the bandage contact lens is of a very good help. Usually we get a bandage contact lens which is of 14 millimeter diameter, but we can get up to the large BCLs which are up to 20 millimeter of diameter. So we need to reassess this at a week or 5 days or 3 days, and we need to put a stitch if we do not find a reduction in the leak. So my conservative approach would be of 4. One is aqueous suppression. That is, if we have less amount of aqueous in the blade, it is going to leak less. So it is being achieved either by adding a beta blocker or TCA inhibitor. Secondly, a topical antibiotic. Usually a topical antibiotic is an irritant. So if we use something like a 4-quinolone or a gentamicin, it is going to irritate the surface, and epithelialization is promoted, and reduction of steroids. And we need to give adequate lubrication, because if the surface is dry, it is going to, the blade is going to friability. The friability is there, so that there is more chance of leak. And recently, from a paper from LVP, we have seen that they had almost managed to get a leak repaired with the use of oral doxycycline and the large diameter of bandage contact lens. So whenever I get something like a tissue necrosis towards the limbus or a leaking blade, which is not extremely gaping or extremely brisk, so we can use a large bandage contact lens and a submicrobial dose or a 100 milligram twice daily dose of doxycycline for a period of 2 weeks. Usually the blebs can conservatively managed without getting this to a operation theater. So whenever it leaks, if the leak is real bad and we cannot manage it conservatively, we can take it to OT. And here what we do is we get small nicks with the standard phacocyte port knives at the limbus, depending on the extent of leak, and we take a nylon from the cornea and reverse it and take it back through that cut and tie it with a throwing knot. It's like horizontal mattress, and put 3 of them. And bearing it perfectly, so mostly it helps. This is for immediate post-op if you're finding that the limbal edge is really leaking and we cannot control it easily. So coming to the lead bleb leaks, usually it is a diffuse weeping bleb that is covering a large area, or it is a localized leak. It may be a localized leak. And usually it is an interplay of ischemia, avascularity and necrosis, where the management is essentially surgical, and the surgical technique depends on the surface area and also the health of the surrounding tissue or the lead tissue. And the goal of repair is to repair the weak conjunctiva and restore ocular integrity and preserve the bleb function. So either it can be done with a conjunctival advancement or a free conjunctival graft, or a excision or a bleb excision with a rotational graft. This is one of my recent patient who is a 60-year-old gentleman who has been presenting 10 years following trabeculectomy with antimetaboloid, and he had presented with excessive tearing with a very low vision and very low tension, And with record, we saw the tension being almost unrecordable for over 6-7 months. So in this case, this is a blade which is centrally leaking. It can be easily seen. So we start to, from outside of the ring of steel, going to the healthy tissue, dissecting well, and making a pocket in the subtenon space. And covering all around this area. Then we attack the central necrotic area, taking the roof of the cystic bleb, deroofing it completely. At this point, we just see whether the complete hooding along with the conjunctiva is possible or not. And this small film, I usually preserve it because if I put a sclera or a corneal graft, sometimes the intraocular pressure following is difficult to manage. And we give relaxing incisions from the fornix. And then ultimately securing it here, like the same mattress suture like this. Can I take another minute? Is possible? Okay. So 3 weeks post-op, the picture is like this, which is gratifying, and the patient over a period of last 4 months has gained a vision of 6/18 from finger counting. And if there is a scleral melt, if we feel like this, and there is a real large hole, specifically from the limbus, usually I prefer to take a scleral patch from the same person, reverting it, or sometimes we have also used corneal graft if the leak is really large and difficult to control. But I am not very happy with the amniotic membrane because using amniotic membrane, I have seen that it ultimately it leaks again. So it has got limited use, I presume. So what to expect in follow-up visits? I usually start with a topical fluoroquinolone with a topical steroid 4 times daily. If I do a conjunctival advancement, I usually expect healing of the edges by 7 days, and we are safe if there is no leak within the first 10 days mostly. If there is a free conjunctival graft, the edge should be vascularized within 7 days, and if there is a melting stars or there is a chance of necrotic edges, it is better to start oral doxycycline and application of a large bandage contact lens and assessing the patient every 7 days over a period of a month or so. And sometimes we need to deal with the rise in intraocular pressure and start anti-glaucoma medication. So the thing comes in our mind whether there is a better alternative like Ologen and things like that, but we know that despite all these new surgical, non-surgical alternatives, trabeculectomy with mitomycin C remains the gold standard. And we must remember that if we put a stitch in time, that is an anchoring suture in the limbus with a tight conjunctival closure, mostly we do not have a leak in the early postoperative period. And recently I have been using the subtenon mitomycin C injection, and I personally feel that with a wider application of mitomycin C, the localization of anti-metabolite in particular area of the conjunctiva is less, and the ring of steel formation and subsequent cystic change and break of the epithelium is really less. If we can limit the amount of mitomycin C that we are injecting within the bleb, and that is it. So thank you for your kind attention. Thanks, Dr. Purvi.
Rest of time we'll, yeah.
You said you take a scleral graft. From where do you take it? And said you reverse it.
Yes, I usually do that. I do not take a scleral graft. We reverse it. Like from the, huh?
Just turn it.
Not the epithelium. We just turn it like this.
Take a partial thickness graft from surrounding tissue and just put
Turn
it
it
on.
around. Just rotate it.
Just rotate it. Yeah.
No,
No,
turn it.
rotate it.
Rotational graph. Yeah.
You are talking about bleb revision.
Mitomycin.
Sponge. Yes. Immediately after, just post up at day 1, day 2, it can be very low, extremely low. Yes, from day 1, day 2. Yeah, but it's rare. It's not for all the patients. I see it is maybe a immediate MMC burn or something like that. Silvery body shock because of the injection. Yes, sir.
I saw you when you're giving that subcon mitomycin.
Yeah.
You were trying to contain it in the posterior. Any particular reason?
Yeah, because we want to save up the totipotent stem cells in the limbus. So if we essentially want the injection to be in the subtenal region, because while we are pushing the injection, I usually use a bevel down 30 gauge needle and give it in a very small amount. So if I feel there is no resistance, then I withdraw it. Because if there is no resistance, meaning the whole amount of injection is going in the subconjunctival space. So if it is really in the subtenon region, there will be some resistance. So thereby probably we will be able to manage those things like immediate pressure drop and things like that. So I have an IC in the Sunday, so you can come and attend that. So this is a different IC.
Yeah.
So let us continue with that.
We can always have the discussion, but in the interest of time, we would actually keep the discussion till the end and move on with the talk. Invite Dr. Mayuri Khabar, madam, for a talk on overfiltering bleb.
Thank you, Purvi, for giving me this opportunity. Many part of my lecture is already been covered by the previous speaker, so I will try to push it off fast. It's not moving. The slide is not running. Okay. Still, we know that the trabeculectomy is a mainstay in the management of glaucoma, though many other options are now available to us. Leaving postoperative hypertony untreated can result in a permanent visual damage, and that's why it is crucial that we look out for it continuously and address it immediately as and when required. How to define the hypertony? There are two ways of defining: statistical hypertony or the clinical. For me, if the pressure is less than 6, I define this as a hypotonous eye. An IOP that is low enough to cause clinically significant complications such as visual loss is a hypertony. That can be a definition. And it is associated with chorioretinal folds or the optic nerve edema and vascular tortuosity. And persistent folds will develop the fibroblastic membrane on that, and this visual loss then becomes permanent. So overfiltration can be early or late in the post-op period, and it could be secondary to the ischemic avascular thin bleb because of the lot of use of mitomycin these days. When to intervene in such case? As I said, if patient has visually significant symptoms, then we have to, because it can lead to choroidal effusion. This also leads to persistent ocular pain, and sometimes it results permanent loss of vision. And how much to be respond to depends on what is the cause of hypotony and how much is the extent of the problem. So the late onset can be managed by injecting autologous blood into the bleb area, though I am not using it much. But the theory is the fibroblastic activity will be there, and that will have fibrous or scarring in the subtenons capsule. Let me share one case of mine. A young male who is myope, we discussed that before also, who had the mitomycin C also for the TREB, and it was 200 microgram 2 minutes. And the post-op, there was no leak, but the pressure was 2 millimeter of mercury. Conservative management in form of steroid atropinization was done. You can see the large overfiltering bleb, shallow chamber, cataractous changes are coming up, and the huge corridors even seen on the slit lamp. So conservative management failed in this patient. So we took the compression suture. Using the 9-0 nylon suture, the horizontal compressed suture was taken at the limbus to tamponade the conjunctival incision to prevent the oozing and facilitate the healing. As you see here, the first suture was passed from the limbus, and the posterior edge was taken through the posterior edge of the bleb, and try to pass this suture through the conjunctiva, not full thickness sclera, full thickness scleral flap as well as part of the sclera. But believe me, it is very, very difficult in a very hypotonous eye with a huge bleb. This is the post-op day 1. You can see the compression of the bleb, and after 3 months, the compression is ultimate, and the pressure has gone up to 12 millimeter of mercury, and chamber depth is now normal. This is another patient, a small clip showing you overfiltering bleb. A suture is passed from the good amount of the bite has been taken, partial thickness cornea, posterior cross is made, and 4 throws, and genuinely tighten the suture. Once you have done it, rotate the knot and bury it into the. So it's a very simple technique, but one can manage it. This was done only 3 days back before I came here, but it was huge bleb, unrecordable hypotony. The surgery was done 5 years back with macular hypotony and the scar at the macula. So visual outcome, we were not aware of what will happen to this patient. But first horizontal mattress was done here. It will compress the scleral flap also. Gonioscopically, this patient had a huge internal window, and 2 horizontal mattress and multiple vertical compression sutures were taken in this patient. Now overhanging bleb is another form of overfiltering bleb. It is well documented complication, and it is more seen with the effect of continuous lead movement. Now hypotony, because of this overfiltration and external leakage, can be a serious complication, gives you foreign body sensation, dysesthesia, Dylan formation in that part of the cornea, and cosmetically also it is not acceptable. So when you have this kind of patient, you have to manage. Conservative management always starts with the lubrication. Laser can be applied to the bleb margins or cryo application, but I am not using those because in the past we have tried that and it's not working in my hand. So there are 3 strategies that can be done: partial excision of the overhanging part of the corneal portion, and then you can have a free conjunctival autograft, patch graft of the same patient, or you can do the Bleb excision with conjunctival advancement. Remember that these procedures may compromise the Bleb function, so counseling of the patient should be done that they might need anti-glaucoma medication in future to control the intraocular pressure. So this is the overhanging flap, and it's not firmly adherent to the cornea. Just lift it with the spatula and bring it up to the limbus and cut it. This is a non-functioning part of the Bleb, and then you take the suture in that particular area. Another male patient, high myope and a soft eye. Surgery was done long back. You can see the multicystic Bleb, and it was a leaky Bleb. Alternately, it healed, the leak will seal little bit and patient will regain the vision. So it was a fluctuating vision. This is a very small thin area. And this patient had advanced conjunctival advancement with the hooding, and this is 3 months post-op. Now, I have selected this particular patient particularly. Patient, we take multiple sutures here, and they do feel foreign body sensation. They insist upon the removal. So when we removed one suture on this part, immediately there was a retraction of the conjunctiva, because a smooth Bleb that we have preserved. So remember not to remove this suture and try to bury all the nodes. So this is a small clip. First, demarcate the Bleb and remove cut the conjunctiva in the peripheral part to the limbus, up to the limbus, and give, if it is not enough conjunctiva, then you have to give horizontal incision just to make it loose. Then remove the overhanging part. If there is nothing like overhanging, make the conjunctiva raw in this particular. Debridement is to be done, otherwise it will not stick there. Dr. Dipanjal has shown us making the groove, but I don't make the groove like that. I just debride this part of the epithelium. And then first anchoring suture is to be taken very nicely, and then rest of the suturing, either continuous or interrupted, can be done. Here you save the functioning Bleb, but if the conjunctiva of this Bleb is not good, just like a necrous conjunctiva, you have to sacrifice the Bleb. Just like this, a scleral melt is seen. In that area, we use the scleral patch graft. We remove the unhealthy conjunctival Bleb, conjunctiva of this Bleb. And then the donor patch graft was used, sutured on it, and we finished the surgery. So this is the post-op result. So Bleb function though is compromised in this particular, but good counseling help us in starting the anti-glaucoma medication later on. Thank you very much.
Now I'd invite Dr. Chandrima Paul for her talk on raised intraocular pressure, because as much as we fear hypotony, raised intraocular pressure and an unachieved target IOP is equally hazardous and fearful.
How do you go back? Yeah, okay. So good morning everybody, and thank you Dr. Purvi for having me in your course. It's indeed a pleasure to be here, and I take you through high intraocular pressure with high and low blebs and what are the strategies that I follow. But my work has been made relatively simple by the previous speakers, because each of them in their talk have covered some portion of this, and I'll keep it absolutely short and sweet. So to start with, trabeculectomy is a surgery which actually the drama begins post-operatively. On the table, however good a surgery you might perform, you have to actually be competent enough to handle the post-operative period, because it's a surgery which is against nature, where we pray. Every other surgery we pray for healing. Here we pray for non-healing, because we limit the fibroblasts and want the ostium to remain open as long as possible. So trabeculectomy, as everybody else said, was started in 1968 and is the gold standard for glaucoma surgery. The limitations being wound healing at the episcleral and conjunctival planes. The early post-operative period, IOP is usually low for several days, but with increased outflow, decreased aqueous formation due to inflammation. In 2 to 4 weeks, IOP rises to the normal range. Increased outflow resistance due to scarring and aqueous formation returns to normal. So the 3 parameters here to be noted at every post-operative visit are intraocular pressure, depth of the anterior chamber, and height of the bleb. These are the 3 cardinal points. So high bleb and deep anterior chamber. So 9 to 15% the literature says incidence. With the rise in intraocular pressure, a few eyes develop high bleb and elevated intraocular pressure. Bleb cavity expands with aqueous but is limited by healing. Bleb wall balloons out. Encapsulated cystic cysts of 10-ounce capsule, high bleb, high intraocular pressure phase, firm tight appearing bleb with few or no microcysts. The risk factors being limbal based flaps, long-term use of topical beta blockers. So just to have a look at that colorful circle that we have here, the bleb wall is non-porous, causes poor fluid movement in the bleb. That leads to compression of the bleb wall, followed by compression of the vessels, and finally raised intraocular pressure transmitted to the bleb. So if you have a look at this, the encysted the encysted bleb that you see out there. So many of us have seen it in our practice over time, and the increased bleb height with absent microcysts that you see that in the UBM. So management of bleb encapsulation, IOP rises but eventually falls at 2 to 4 months in encapsulation. IOP reduction, well, aqueous suppressants can be used temporarily, and sustained IOP rise, bleb needling with antimetabolites can be done. You can do it at the slit lamp, or you can take your patient back to the theatre and do it. And surgical bleb revision, I won't go into the details of that. We've had enough of conversation and discussion on that just before this. And partial or complete cyst excision, and of course you can go for a repeat trabeculectomy. So high bleb with shallow anterior chamber, that's usually due to pupillary block, aqueous misdirection, which we call malignant glaucoma, or suprachoroidal hemorrhage. Malignant glaucoma, posterior diversion and pooling of aqueous in the vitreous cavity, we all know that, triggered by sudden shallowing of the anterior chamber. Conjunctival leaks, overfiltration, you can actually by suture removal it can be caused, and sudden uniform shallowing of the anterior chamber. So anterior displacement of the iris root that you see out there again in the UBM, and the uniformly shallow AC that you see. I'm scared to touch this touchpad here because the slide is moving instead of the pointer. There you are, yeah. So that's it. So management of malignant glaucoma, medical, you have the aqueous suppressants and the cycloplegic. Lasers, well, aphakic, pseudophakic eyes, anterior hilar disruption with the YAG laser, and ciliary process shrinkage by the argon laser or the diode laser nowadays. So surgical, pars plana vitrectomy with disruption of the anterior hilar phase, frequent follow-up as relapse can occur, and long-term cycloplegics sometimes are required, and caution is the other eye surgery, to remember that. So suprachoroidal hemorrhage, clinical features, sudden onset of pain and nausea with diminution of vision, shallowing of the anterior chamber, loss of red reflex, and choroidal elevation. In the ultrasound, you'd see blood in the suprachoroidal space, and the treatment would be topical and systemic steroids, and larger hemorrhages would definitely require drainage by sclerotomy. So that's the suprachoroidal hemorrhage that you see in the UBM. So high IOP with low bleb, subconjunctival fibrosis at the conjunctival or the episcleral interface, and a patent sclerostomy. Management would be intraoperative antifibrotic agents like 5-FU or MMC. Then early postoperative period, postoperative steroids, digital massage, suture lysis. Digital massage, let me tell you, either you need to teach your patient or at least show the patient how to do it. Late post-operative period, check for patency of the sclerostomy, Bleb revision, needling, failed Bleb, or again a repeat trabeculectomy. So the take-home message would be here: intraocular pressure, Bleb morphology, and anterior chamber depth, most important parameters to assess in the post-trabeculectomy eye. High Bleb, treat according to the cause. Low Bleb, that's definitely a failing Bleb, and imaging to be used judiciously in guiding your treatment. These are my references, and thank you very much for your attention.
Questions? Chandrima, can you little elaborate on your way of doing needling?
Yeah, so initially I used to do needling at the slit lamp, and I was very confident. Let me tell you that in one of the best institutes like Moorfield, they always do it at the slit lamp. So they do it very confidently at the slit lamp. You definitely need a gonioscope, and you have to be confident in your gonioscopy. And after you perform the needling, generally we used to use 5-FU, but 5-FU nowadays is restricted use. So if you are confident enough to use mitomycin, as I think Dipanjan had said, the injection of mitomycin, but again, as Shagurikadi said, injection of mitomycin has to be with real caution, because you'd have the IOP drop like the mercury drops in a blood pressure instrument when you release the cuff. So basically nowadays what I do safer is to take the patient to the theatre, explain to the patient that, because if you do it at the slit lamp, you're safe, you don't have to tell the patient much, and you can do it even without the patient knowing about it. But if you take the patient to the theatre once again, you'd have to give reasons why you're taking the patient back to the theatre. But I think it's better to explain to the patient, be on the same page as the patient, and tell the patient what actually has happened, and take the patient back to the theatre, and then do the needling in a supine position, because that I think helps in every other way. Yeah.
You want to add anything? Yes, yes.
We have a lot of VR surgeons also working, especially in the army, along with us. So at that time, somebody suggested to me, why don't you use a trocar? Trocar, they constantly use it. And I found that, when you do with the Bleb needling, as she said, you can do it the OD, whatever, but when you use a trocar, you are able to cut the tissue much better. So even ring of steel, you are able to cut the fibrous tissue. So this is one little tip that perhaps if you use it, you might find that your Blebs the fibrous tissue cuts faster. The other thing also, that there are people who have undergone Bleb revisions, needling in the best of hands, and people who have done glaucoma for so many years, that also can fail. That is the unfortunate thing.
But how do you use trocar?
You just I have a video, unfortunately I can't show you. You just put it into it, and then you just
Put it
keep
into
on
it?
and on. Into the Bleb. So you go the same way as you're using as you do in a Bleb division. Yes, at 26
7-8
needle.
millimeter from the
And
limb
then you just go in there and you keep cutting in that manner. And the best is, because it's got two edges by which we have to cut it, it cuts very well. So that's
Sharper
interesting. It's very sharp. You would be careful. You could be careful when you're doing it. So in fact, even when you go to the edge, as has been described in various books and also in YouTubes, that when you're going into when you're doing the Bleb revision, at that time when you come to the edges of your lamellar flap, then you're supposed to be actually entering. Now that is the tricky portion. What do you say, the expert panelists out here? It's very tricky, because you can't see oftentimes. Oftentimes blood comes in. So this one, at least you are able to do it, and very gently then you'll be able to perhaps go even into the, go beneath the scleral flap. But you have to be very careful. These procedures are not that easier said than done.
About the trocar, actually one thing I would be a little wary about is the force that you use to do it. Because with the needle, your force is much more controlled and less. Yeah.
Whatever, these are things which have been tried, and we've all tried them, but each of us realizes that you have to be very careful. So now you've got a double-edged sword. There you have one little edge. Here you have two edges. So you've got to be very careful, but it works. That's what happens.
See, the blanching of the conjunctiva preoperatively helps you in reducing the bleeding. Or sometimes it is horrible bleeding. The whole blab is full of it, and you can't see the flap edges. So I mark if I can see the flap edges, I mark it before I do the needling, so that I can easily go underneath.
Actually, through the conjunctiva, if you can identify the sutures and you know where your flap is, it becomes very easy. So go near the suture first, so you know you are under the flap, and then start dissecting.
The basic problem is that the wall is no more so translucent when you do, yeah.
Before you start, you just blanch the conjunctiva, identify the sutures where you are, go near the sutures, and start from there.
Actually, in most, say, glaucoma surgeons, what happens, a failing bleb is not immediate post-operative. At least that is what I've seen in my practice. A failing bleb comes after, say, about a year, 2 years, 3 years, and then it is very difficult to identify where actually was your ostium and where you would actually needle to think. So these are the practical things which you face once you have a failing bleb, 1 or 2 years later post-operative trabeculectomy.
So we move on to the second last presentation about Dr. Paresh Dave from Vadodara on the most dreaded complication, that is blebitis.
Right, so a very good morning to all of you present here, and thank you, Dr. Purvi, for this opportunity. Right, so bleb-related infections are rare, but they are potentially devastating, and it represents a wide spectrum of disease with infection that may be limited just to the filtering bleb, which is known as blebitis, or there may be associated anterior chamber inflammation with intraocular extension leading to endophthalmitis. So basically, bleb-related infections can be divided into blebitis and bleb-associated endophthalmitis, which can further be subdivided depending on the duration post-surgery into early onset and late onset. There is another Greenfield classification wherein they have divided bleb-related infections into stages, where stage 1 is blebitis with the infection being limited to the bleb and no anterior chamber inflammation. Stage 2 is wherein you have some anterior chamber inflammation but the vitreous is clear, and stage 3 wherein you have vitritis. So the incidence of acute and late onset bleb-related infection ranges from 0.8 to 4%. This is actually higher as compared to, say, acute postoperative endophthalmitis after cataract surgery, which is significantly lower. As far as the causative organisms are concerned, Staphylococcus epidermidis or aureus are responsible for the early onset infections. These organisms are less virulent, and the infection is caused by perioperative introduction of the host flora. Streptococcus species and Haemophilus influenzae, on the other hand, they are responsible for the late onset infections, and these are more virulent, and infection occurs through transconjunctival migration through thin walled blebs. They also produce exotoxins which facilitate their penetration through intact conjunctiva. As far as the Indian scenario is concerned, a similar profile is also seen. A few other specifics are Corynebacterium xerosus for blebitis associated with blepharitis, and Streptococcus pneumoniae for blebitis associated with nasolacrimal duct obstruction. Moving on to the risk factor, we all know that inferior bleb is a major risk factor. Second is bleb leak. A bleb leak increases the risk of infection by 5-folds. Use of antifibrotic agents, which is a norm these days, either mitomycin C or 5-FU, because they alter the thickness, cellularity, and the vascularity of the bleb. The type of surgery is also important. Combined surgeries usually result in blebs which are more thicker and they are more resistant to infection as compared to blebs which happen post trabeculectomy alone. There is also literature evidence to suggest that limbal-based flaps are more susceptible to blebitis because they result in formation of blebs which are more localized and cystic. Post-operative complications like a flat anterior chamber or early wound leak would also result in a bleb which becomes more susceptible to infection. Any prior conjunctivitis or blepharitis is a risk factor. Past history of a bleb infection also increases the risk of infection by 12-folds. Chronic use of antibiotics, because this results in virulent bacterial selection and predisposes to development of bleb-related infection. Systemic factors which reduce the overall immunocompetency of the person are also a risk factor, especially diabetes. The patient usually presents to us with pain, redness, photophobia, discharge, and a reduction in the vision. If you do an examination, the signs are localized conjunctival injection, the classical white on red appearance. There is also loss in the normal translucency of the bleb. The bleb becomes milky because of the accumulation of purulent material underneath. You may also see an associated bleb leak and anterior chamber reaction, and a hypopyon indicates an endophthalmitis unless proved otherwise. So in addition to the normal workup that you would normally do, you want to do a good slit lamp examination, identify a bleb leak if it's present, check for anterior chamber reactions and cells in the vitreous. B-scan, if at all you cannot see the posterior segment in case of endophthalmitis. Microscopy and culture and sensitivity are essential. You can take samples from the conjunctiva, or the anterior chamber or the vitreous tabs. Normally, there is a very poor correlation between the conjunctival organisms that you would find the culture and the AC and the vitreous tabs. However, you can go ahead and do it anyways. PCR, especially quantitative PCR, is helpful for fastidious organisms and also identifying contaminants from the actual infective organisms. So the treatment, early diagnosis and prompt intensive treatment is absolutely critical. So the aim of treatment is to avoid progression to endophthalmitis, because once endophthalmitis happens, the prognosis becomes extremely poor. Because the condition is relatively rare, we have no randomized control trials as such to suggest some guidelines as to how we should go about the treatment. But it is common sense that we need to start with broad spectrum antibiotics and later change if the culture results tell us to do so. Topical steroids have to be avoided for at least 24 to 48 hours unless you see a clinical improvement in the Bleb infection. So this is an example of a regimen. You give a combined fortified vancomycin and tobramycin, or fortified cefazolin with tobramycin. So the idea is to take care of both the gram-positive as well as the gram-negative organisms. Or you can also give fourth-generation fluoroquinolones. However, this treatment, you need to give a loading dose for it to be effective. A loading dose consists of giving 1 drop every 5 minutes, at least 4 to 5 times, and then start with the hourly regimen. You want to give cycloplegics and also systemic carbonic anhydrase inhibitors because they help in taking care of the Bleb leak if at all it is present. Systemic antibiotics may be considered for if for the infection that is spread to the vitreous. Oral fluoroquinolones or even linezolid is extremely helpful. And conjunctival advancement for Bleb leak may be required later if the Bleb leak does not heal on its own after the control of infection. So prognosis depends on various factors. One is the pathogenicity of the organisms. So we've already seen early onset infections are usually caused by less virulent organisms as compared to the late onset. Extent of infection, blebitis is usually milder as compared to Bleb associated endophthalmitis, and prognosis is better if the infection is limited to the Bleb. Also, the lapse between the onset of symptoms, diagnosis and treatment is extremely important. If the patient comes to you early enough and you start treatment early, the visual prognosis is much better, and also the initial visual acuity is a factor. So we have literature evidence to suggest that on one end of the spectrum, wherein the infection is limited to the Bleb and the infection is caused by less virulent organisms where treatment has been initiated early, 83% of the patient can retain visions of 20/40 or better. On the other hand, if the infection spreads, then 94% of the cases with Bleb associated endophthalmitis, they have a visual acuity of less than 20/200. Even no light perception rates can be as high as 41.2%. Also, positive vitreous cultures are associated with worse visual outcomes because they indicate that the infection is more severe. So as far as the prevention part goes, you want to avoid chronic use of antibiotics. Any conjunctivitis or blepharitis, you want to be extremely aggressive in treating patients who have already undergone glaucoma filtration surgery prior. Patient education is extremely important. You must counsel the patient and tell the patient when he needs to see you so that you can detect such things early, and always check for Bleb leaks. So to conclude, trabeculectomy surgery is one of the most commonly performed glaucoma filtration surgery, with Bleb associated infection being one of its vision threatening complication. Early aggressive treatment is the key to prevent progression to endophthalmitis, because once endophthalmitis happens, the prognosis is extremely poor, and educating the patient regarding the warning sign can go a long way in preventing devastating complications. With this, I'd like to conclude. Thank you so much for your patient listening.
Thank you, Dr. Paraj. We now move on to the last talk of the session, the keynote address by Dr. Kirti Singh Madam. We'll talk on angle closure glaucoma and how does the surgery differ therein.
Thank you to AIOS for this, giving me this honor, and Purvi for including me in the IC. सर्जरी इन AHCG, सर्जरी नीचे वाला थर्ड नंबर, इसके नीचे ये वाला, हाँ, या जस्ट स्टार्ट द प्रेजेंटेशन. Okay. So how is the ACG? Why am I focusing on ACG? Because this is where I work in Guru Nanak Eye Center in Delhi, and this is my actual patient profile data, which is right now being compiled. Over 35 years experience, 3 to 4.5 lakhs patients per year in the Guru Nanak Eye Center. Angle closure glaucoma comprises almost 49% of our patients. Literacy level 43%, primary schooling only 40% patients. No self-earning of 74%. This is our data for the last 2 years. Poor access to healthcare, distances traveled by our patients 62%. This is a few of my patient vignettes of how they travel and how they come and how they are. So this is what we have and this is where we work. And the topography of an ACGI we know is small. Space is small, aperture is difficult to access, shallow AC reduces the working space, lens volume is more exaggerated, it's just like this fat man sitting in a small car. And this all the weakening is there and CCC is difficult. To cap it all, it's a thick peripheral iris roll. Your iris is bulky, flaccid, floppy, atrophic. Pupil sometimes is non-dilating. And this floppy iris just keeps coming out of the section when we are doing a surgery. We know, and as per the data analysis, that 52% of phakic patients develop significant cataract after TRAB within 2 to 5 years. Phaco energy and fluid increase to 33% risk of failure of functioning blebs. And prolonged low-grade inflammation is partly responsible. Many of these patients who come to us with filtering blebs and coexistent cataract, a common scenario, as I said, very often have also advanced glaucomas. So how do you work in that? We did a study on that, and this is part of my talk, which we did way back, effect of phacoemulsification on bleb morphology, both qualitative and quantitative. And what we tried to do was protected the bleb ostium, internal ostium, by sodium hyaluronate to reduce the effect of the phacoenergy on the bleb and to reduce the inflammatory mediators going in at that time. We tried to take mature blebs. Mature blebs is more than 2 years preferably, at least 1 year old bleb. Don't try to do a cataract surgery in a very young bleb. And this series had 6.8 years mean. So this is how we did this surgery. We do it. As we say, it's a very shallow AC. It's a bulky, it's called as a volcano lens configuration. The lens is always, protruding out. So it's preferable to do viscodispersive, because if you put heel on, it's difficult to remove it. And then we protect the functional bleb with the visco cushion. So this is just the phaco surgery being done, low fluidic, slow phaco. And we have protected the bleb with the visco cushion. At the end, please do a lot of polishing, as these patients get PCO very frequently. So IOP reduction was there, but it was positively correlated to the preoperative IOP, and the visco cushion group had the minimal bleb disruption, both by the height, extent, and vascularity as per IBAGs. This is the pictures of the bleb height and the bleb wall thickness in the control group, in the visco cushion, and the average of the patients. So visco cushion, basically the end conclusion was that visco cushion did protect, and that is what we've been doing it now since that study. However, despite the visco cushion, we did on the ASOCD, we found that macrocystic spaces, wherever they were present, decreased in all the patients, all the filtered eyes, whereas microcystic spaces reduced. Bleb height also was maintained in 66% patients, but overall it was reduced by 23%. So even though with all the precautions you take, the bleb height and the bleb extent does take a beating, so bleb functionality should be monitored more frequently and more consistently after doing a phaco surgery. This is another patients we have again often, phaco in very shallow eyes. This was an overfiltering bleb, and it is almost a conjugolenticular touch with the cell count, because of the conjugolenticular touch being 1500. And we tried to do a soft shell technique. CCC was extremely difficult, and there was very little space also to put that otratas in. I just had to do with the cystitome. So again, I'm trying to do the visco cushion in between for the bleb, and this was relatively soft cataract, and we tried to do an aspiration And again, polishing has to be very meticulous. Here, because of the AC, this shallow AC was there for a long time, we did something which we have just presented, internal revision, where we recreate the PI and just pull out the stuck iris to the internal sclerostomy. This patient had post-op shallow AC, and only after a long time of atropine of 2 to 3 days, it started reforming, and then subsequently she did well. Other issues in ACG are the pupil issues. Pupil is very often myotic because the iris is atrophic. So we either use a pledget dipped with midriatic in addition to the dilator drops, or you do manual dilatation or Kugelin iris manipulators or iris retractors or Malugan rings. So again, keep these ready when you have an ACG patient. I know most of you are in practice, you do that, but in a government setup, sometimes they're not available, so you have to make it ready. Then we have another situation where previously we were trying to prevent the iris from, the filter from failing. Here we already have a failing filter. Make the audio less, please. So this is what I was talking about, the floppy iris. It comes up like the genie or the lamp. It just keeps coming out. And you have to ultimately do a small surgical PI on the temporal side, and then it just remains inside. And the trick is not to keep on depositing it because it will keep coming out. So I just do a small PI and then it just remains there. This bleb was intra-op needling was done along with phaco because this bleb was failing. So we combined it with that and we have good results with that. So the surgical interventions in ACG to maximum outcomes are protect the bleb, operate on mature blebs, minimal 1 to 2 years, optimal 1 to 2 years, minimal 6 months. I would try to not do within 6 months, but 1 year. Use viscoelastic cushion to protect the bleb through the sclerostomy. Macula prevent phototoxic damage. Iris is floppy. Do a PI for recurrent floppy iris. If you can try synucleolysis, goniosynucleolysis, and synucleolysis anyway has to be done for the phaco to be done. Keep CTR and iris hooks ready. R-related complications are pretty frequent. So for the recurrent prolapse, do a small surgical PI subincisional. Prevent PCO and ACO by a meticulous polishing, rigorous polishing, and give steroids for 8 to 9 weeks. Bleb failure is common, and the first sign will be reduction of microcysts and macrocysts. Height will remain for some time, and then vascularity does increase. And if that happens, do a very early bleb needling. So monitor those failing blebs. Fortunately, we only had one of these cases, but that one was enough to teach us. ODR does happen. So try to, if those patients with the large, especially in children when we have the mature cataracts and the operated filters, now I started doing AC maintenance always because ODR, we did have this patient, this young child with ocular decompression retinopathy. As I said, phototoxic damage can happen because macula is very vulnerable and these patients are advanced glaucoma. So have the filter on always when you are doing the suturing. And I do not prefer to give oxygen to my patients unless patient is really symptomatic and is a COPD patient. I would not give this oxygen. I don't know what the tendency here is, but most of our hospitals, they just give oxygen because patient feels more comfortable. Inflammation in glaucoma scenarios is more, so I do stop my prostaglandin and pilocarpine 7 to 10 days before. And gonioscopy is done always before any cataract surgery to confirm the open sclerostomy. Interval between TRAB and phaco is 1 to 2 years. Advanced damage is common, so have realistic goal to the patients. When you have cataract and PACG both, then IOP control alone may just control the pressure. IOP control with 27% reduction may happen just with the lens extraction alone, and the AGM requirement is less. And this was our study, which was concluded more than 2 years ago. And these patients are doing well. We are not proposing clear lens extraction, no way. But if they have cataract, just go ahead with just and cataract surgery in the PACG eyes, and the angle obviously does widen out, and the IOP is controlled. IOP reduction happened in 95% of our patients, with a personal reduction of 42%, and reduction in the AGM was 92%. And there was no progression at 6 months follow-up. It was too small a follow-up to document progression, but that was it. And please remember, again, the type of patients we had, we would prefer to do a combined cataract and trabeculectomy if both the scenarios come in, because such patients cannot afford to travel again. And this is what we do for the patients who have advanced cataract and maybe moderate glaucomas. We don't trust on the medication, and we can also do a SICS trap, the WVY incision with the trabeculectomy combined. Shallow fornices are there mostly in ACG cases, unhealthy conjunctiva, and we just documented that goblet cell reduction is there in ACG cases much more. Inflammatory markers are more. So we do a conjunctival suturing technique of the frill incision 1.5 millimeter of the limbus, and this has been already published. And this is the last video of 30 seconds with permission. This is how we do the conjunctival frill technique. We do it for all glaucoma patients, but for ACG especially, where you have a very shallow fornix, this really helps. So this is a marriage of convenience between fornix-based and limbal-based. And you remove the sutures on the slit lamp. The releasable sutures are removed within 7 to 10 days, depending on the IOP and the Bleb, and the congenital sutures in 3 to 4 weeks, depending on the healing. We do a round body needle technique for this. So remember patient profile, coexisting cataract, 6 trab is a good option for patients who can't come arm, and conjunctival care for the ACG situations. And this is our CME on step-by-step glaucoma surgery if you want to go through that. Thank you so much for this opportunity.
Thank you so much, ma'am. Yeah, we have just 3 minutes. Any quick questions or comments from the audience?
How early needling should be done if you notice flat band? And how early you can do needling?
Needling is basically for failing blebs. So the moment you feel that the bleb is failing, that's the time you do the needling. It's not for failed blebs, it's for failing blebs, yes.
But how early you can, like once you notice, then you can, 2 weeks, 4 weeks, like any time period?
No, you can do it immediately. There's no need to wait for it. As long as you and the patient are on the same page and speak to the patient and do it.
Can I make a comment on that?
Yeah.
We just presented a paper on needling yesterday, and we have successfully done needling for even 15-year-old blebs. So even in failed blebs, and especially do an gonioscopy to see if it's internal failure, internal blockage, or external. If it is internal blockage, like I showed on that picture, just free up the ostium by ab interno, and then follow that up by needling. It may work, and there's no harm in trying, because the other option for a failed bleb is either repeat surgery or you give anti-glaucoma medication. So it's always worth a shot. It may work. It very often surprisingly works. So do that, but always rule out an internal blockage. And again, I do needling now with mitomycin C in failed blebs because FU doesn't work. And your second question was that, what stage? As she said, you can do it as early. In fact, many of the surgeons now take part of needling as part of their protocol post-op. If they find the bleb height is reducing and the vascularity is not going down, all the signs of early failure, you intervene then and there. And you remove the needling and you get rid of the gritty sensations or the fibrosis, because earlier you intervene, better it is. But if you have a flat bleb due to other causes, you have to rule that out. It may not be just a bleb failure, because needling will only work for failed or failing blebs.
Okay. So I thank everybody on the panelists, all the co-instructors for being a part of this session, and hand over to the next incoming faculty. Thank you.